here tonight with our team. There's a huge audience out there, and we have a phenomenal program for you all tonight. So I'm really looking forward to you all sitting back and listening, because we've got many good stories and some very brilliant physicians that I have the privilege of working with who are going to share with you some sort of thoughts and aspects of heart disease and how we as a community and you, every one of you in your seats, can make changes in your lives. I just wanted to say the video that we had before, that was something we prepared at the end of last year to celebrate our first year as an integrated group in the medical group. So we played that to our physicians, and it's actually up on the YouTube site. Before we launch into the program this evening, I just wanted to set and frame something about cardiovascular health and really the impact it has on the lives of Americans. I just wanted to share a few statistics to get you thinking before we introduce our speakers tonight. Heart disease is the #1 killer in the United States. There's about 86 million Americans that suffer from heart disease. 1 in 3 Americans. So look around you tonight in your seats. It's quite scary. At your tables, there's 1 in 3 of you who suffer some aspect, be it hypertension, high cholesterol, or may have had a heart attack in the past. In America, someone dies every 40 seconds from heart disease, and it's estimated by 2030 the impact of this disease on our society is going to cost us all about $1 trillion by 2030. These are sobering facts. Something else that I just read today that sort of resonated. A lot of people think heart disease is a man's disease, yet heart disease, stroke, and cardiovascular diseases are also the #1 killers of women. Apparently, 400,000 women die every year in the US, and 1 minute a woman dies somewhere in this country from either a heart attack or a stroke. So these are the sobering facts, and now I'm going to lighten up a bit. We had Valentine's Day last week, so we all thought of someone who's nearest and dearest to us. And tonight, I'd really like us to be optimistic, because each and every one of us can do something about this killer disease. Behind this public health issue, there are simple things that you can do, like exercise, taking care of yourself, not smoking, and Dr. Boyden's going to be sharing some of that with you tonight. I also want you to be aware that we're on the sort of brink of a new frontier in medicine. A lot of the traditional ways we've taken care of patients are going to dramatically change in the next 10 years and for future decades. So stuff that's coming out like molecular biology, precision medicine, the abilities of physicians and scientists being able to map your genome and predict what may happen in the future is going to radically change how we approach medicine. And Tom Boyden is going to sort of touch on some of that tonight. We're also going to hear about heart attacks from my colleague Dr. Maida. And I work in the cardiac intensive care, so I see every day the impact of heart attacks on people's lives. And I was just thinking, how has it changed in my career? I'm in my late 40s. When I was, say, in my teens in the 1970s, the chances of surviving from a heart attack was pretty much negligible. This day and age, it's phenomenal. That survival or the death rate from heart attacks is well below 10%. So what's changed in the last sort of 4 decades? How have we become so much more successful? Well, one thing is public awareness, and the stuff we have out there on display today, the stuff that you guys can do in terms of CPR and being aware of your health is probably one of the most important factors that have impacted the survival from heart disease in the last, 20, 30 years. The other things are the interventions that my colleagues can do in the cath lab, advances in drug therapy, And you know, that's made a huge, huge impact. So tonight, I'm very excited about some of the stuff you're going to hear. I'm very privileged to have a previous patient with us tonight. So I hope you sit back and relax and enjoy the program. Just before we get started, I just wanted to say, to be efficient, we're going to have our speakers present tonight. You've got these little pieces of paper on your table. So if you have a question, as you listen to the presentations, write down your question and we'll have some trackers come and collect those pieces of paper, and then we're going to have a question and answer session at the end of the evening. So without further ado, I'd like to launch this evening's presentations. I'd like Tom Boyden to join us on the podium. He's going to be talking about preventive cardiology and how to stay healthy. I'm very privileged to work with Tom as one of our team members. He's a non-invasive cardiologist. He got his medical degree from Boyden University in Illinois, and then he undertook further training in preventive medicine at the University of Michigan. Tom's specialty is really the future of our cardiovascular specialty, if you like, because wellness and prevention are becoming more and more important. So, welcome, Tom, and we look forward to your presentation.
Thank you very much, Pam. Thank you very much for coming tonight. I'm very honored to be here and speaking with you. I'm also very honored to be working with such a wonderful group. I think you saw from those videos we are doing some amazing things. And one of the reasons I wanted to come and join this group was because of what we're doing on the end of care after people have events. But I also wanted to bring to that spectrum of care, the continuum of care, what happens before you get to that point, and are there ways that we can help prevent more and more people ending up with heart attacks and the consequences of them. And so that's why I'm here. And I want to share some of the things that I think about every day when I see patients and when I'm talking to patients, and I'm talking about things individuals can do. I always have in the back of my mind some of the things that really drive why I came into this. And I want to share those with you. I don't want to bore you with statistics, but I am going to show you a few things that really do keep me up at night and make me think, how can we change our healthcare system to improve the health of our country? I'll talk to you a little bit about what we're going to be doing through our own prevention clinic. And I want to talk to you a little bit about what you guys can do at home, not only for yourselves, but think about how you can take this and bring it into your family fold or your social networks and start making change for everyone. So, similarly to what Penny was talking about, when we're thinking about cardiovascular disease, we know, particularly here in Michigan, 1 out of 3 people is going to die from cardiovascular disease. And while we've made great strides in helping prevent death from heart attacks, we're still seeing a lot of death. It's still the #1 cause of death. We're spending over $17 billion in our state alone on cardiovascular disease. And Penny talked about how we're going to hit $1 trillion in spending in the country by 2030. We're already spending over $500 billion. We might hit that well before 2030. We know cardiovascular disease is not just specific to the heart. We're seeing an increase in strokes, and while strokes still fall way behind in terms of the numbers compared to cardiovascular heart attacks, it's now the #4 cause of death in the state of Michigan and the #3 cause of death in the nation. So we are still, similarly to the U.S., still the #1 cause of death here in our state. And while we've made strides in improving the death rate from cardiovascular disease, we're still seeing a high incidence of the impact of cardiovascular disease, and in Michigan particularly, we are one of the highest states of having heart disease and the consequences of it. So I think it's really important for all of us here in this room from the state to think about this. Because we also have one of the highest rates of preventing heart disease, which I think is very encouraging. If we're having high rates of death and high rates of disease, we have a unique opportunity to change that, and I think that's incumbent upon all of us. I want to share everything under yellow here is Michigan statistics. And it's a little bit sobering to me, and I'm hoping to make an impact with this, with your help. But if you take a look at this, and I don't know if it's too hard to see, I'll walk you through it. These are predominantly risk factors for cardiovascular disease. Are you a smoker? Do you have high blood pressure? Do you have high cholesterol? Are you diabetic? What's your diet like? How active are you? All those sorts of things. If you take a look across the board, we are not getting better in any of these things other than smoking. We've decreased our rate of smoking to about 20% in the state. That hasn't really changed since 2009. It's way behind the nation, in my opinion, and we're lagging behind the nation in lots of these critical statistics. Our blood pressure is getting worse, our cholesterol is getting worse, our weight is getting higher. The consequences of being overweight is causing diseases like diabetes. It's making high blood pressure worse, it's making cholesterol worse, and those are the things that are driving disease. And part of the reason that we're getting overweight and these things are happening is we're not eating well and we're not active. And we can see that in these statistics. This is something that may be hard to see, but what I want to point out is this is healthy weight people. And people, when we talk about healthy weight, we're talking about a height to weight ratio. We're not talking, a specific number. It's individualized. But if you look at this, since the late 80s, we have had a dramatic drop-off, more than almost 12% decrease in the percent of people who are considered a healthy weight. And there's only less than 30% of people in our country currently who are considered healthy weight. And that is not unique to gender, it's not unique to race, and it's not unique to income level. The differences between the groups might be a little easy to see, but if you look at the trends across the groups, it's going down for everybody. So we're doing things wrong here, we gotta figure this out. And again, just to kind of point this out, if you look what was happening in 1990, you look at that map, a lot of the country was actually at a pretty good weight. We didn't have a lot of obese states. We had lots of states that had less than 10% obesity. Michigan, I think, was in that, I can't see from over here, that 15% or so category, 10 to 15%. But look where we are 20 years later. We're one of the biggest states in the country, and it's only getting worse. We're not getting better. If you take a look at the projections from what the government is telling us, this is pretty sobering as well. Back in 1960, we had great rates in terms of obesity overall for the country. It's had a dramatic uptick. And the projection by 2030 is that over half of our country is going to be considered obese. And that has a huge impact on disease. Obesity is not just linked to cardiovascular disease, it's linked to cancers. It's linked to sleep apnea. It has significant impact on orthopedic issues. People are always coming in and talking about how they can't exercise because their hip hurts or their knee hurts. And this is part of the reason why. We know it directly drives diabetes. We know it increases the stroke risk in patients. It causes liver disease because not only are you seeing abdominal fat, but you also have fat deposits that get in the liver and affect the liver function. It's left unchecked for too long, you can develop cirrhosis. So these are all things that we really have to consider, not just about cardiovascular health, but our overall health. And when you look at that, and you think about obesity and all those things tied to it, it's driving over 80% of what we spend for healthcare in this country. And we have to figure out how to change this. And really sobering to me and really kind of disheartening to me is we're not just seeing this in adults. This is older data and it's only gotten worse. We're seeing significant trends in obesity in our children. And those, we are the largest nation in the world with our kids. They are the largest in the world. And what's sobering, I don't know if you can see it, but the same diseases I just listed for adults that are associated with obesity are the same things we're seeing in children now. So we're talking about kids developing adult diseases at an early age, living longer with the risks of those diseases, living longer with the complications of those diseases, needing more access to healthcare because of them, being in the healthcare system longer because of it, likely potentially having shorter life expectancy because of it. And if you think about just a few of the things we talked about, we know obesity more than doubles our risk of dying. We know diabetes increases our risk of having a heart attack by about 4 times if you don't have it. And we know hypertension, particularly if it's uncontrolled, causes more than 50% of the strokes in our country. So that kind of brings me to where I'm at and why I came here, because this is really what got me excited. When I first started my training at the University of Michigan, I apologize to any Michigan State fans, I came in with the intention of being an interventional cardiologist. And one of the first people I met at the University of Michigan was Kim Eagle, who is a real pioneer in cardiology and preventive medicine. And when I told him that I was planning on being an interventional cardiologist, he said, "Oh, that's too bad." And he said, "Well, if you ever wisen up, come talk to me, we'll talk to you about some other things." And I did wisen up, I think. Ryan made the truth. One of the reasons I came into this is because I think we have an incredible opportunity. We obviously have a huge problem, but we have an incredible opportunity. And one thing I like about this is we can really look at the burden of cardiovascular disease not only on a population level, but on an individual level. We can think about ways that we can tailor care to individuals. We can think about ways we can tailor care to populations, to societies, and to our community and beyond. And we can always look for ways to center it on you, on you as an individual. One size does not fit all. One recipe is not the same for the next patient. We have to figure out ways, similar to what Penny was talking about earlier. What are we doing with genomics? What are we doing with new types of therapies that will be right for one individual, maybe not for the next? And so the whole purpose of what we're doing is to look at you as an individual and say, how do we help you? And in my opinion, we are a very comprehensive group. It's not just about me and the prevention clinic. It's a multidisciplinary team. I work with nutritionists on a daily basis, clinical psychologists on a daily basis. I think you met some of the exercise physiologists that I'm lucky enough to work with. It's a wonderful group of people, all focused on your health and your well-being. So we look at not only people who have disease, who have had heart attacks or strokes, or maybe had angina and ended up with a heart catheterization and a stent. But we're looking not only to take those patients and prevent the next event, but taking a look at patients who are at high risk, have a lot of those risk factors that we listed for having cardiovascular disease, and figuring out how we change those risk factors. And we're also taking a look at patients that might have family conditions that predispose them to having heart disease, and figuring out what we can do for them. We not only go through lifestyle recommendations for you, we'll talk about individual medical therapy plans. And like I said in that video, kind of promoting our whole platform here, we really, I think, are very unique. I left U of M, and we did not have this, and I'm very excited that we got this started here. We are working with the Department of Psychiatry and Psychology, and we are focusing on specific things that really affect whether or not you're going to develop disease, or if you developed it, how your psychological well-being is affecting your relationship with your disease. How can we get over the barrier of maybe depression or something else that's affecting how you take care of yourself? We do, in addition to those sorts of things, take a look at advanced lipid testing. Some people are going to have, this is kind of, it's not the norm. It is something that's been done in the past, but it's not the norm anymore. But it's still critically important for people who have seemingly okay-looking cholesterol numbers. But maybe there's something different about their cholesterol that still makes them high risk for disease when we look at those in particular individuals. There are genetic tests that we can do to look for familial conditions, genetic conditions that cause high cholesterol that also make you at high risk of heart disease at a very early age. New genetic tests are being developed every day to take a look at how individuals will respond to specific therapies. And we're currently in the process of rolling out a new clinic that's rolling out some of these new medications that were just launched at the end of last summer, the beginning of the fall, really aimed at lowering the cholesterol that we hope within the next year or so we'll know the information, are also going to lower the risk of having a heart attack or stroke or dying because of it. In In addition, if you need it, we can get you into cardiac rehabilitation if you've had an event and it's just slipped through the cracks that weren't referred, we can refer you. We have programs specifically tailored to people with risk factors that are very similar to cardiac rehabilitation in terms of getting you in, getting you on an exercise plan, getting you to meet with a nutritionist, getting you to meet with one of our psychological counselors and figuring out are there issues that maybe you're struggling with that you didn't want to talk about to somebody, but now that we're giving you the opportunity and that environment that's there to support you, that maybe you'll talk to us about. And then we're always looking for other ways to help you. There's people that have chronic chest pain, and Dr. Wolschwager earlier was talking about interventions we can do to help people with chronic chest pain. But there's lots of people out there that have chronic chest pain that we don't have any interventions left for. We don't have any medical therapies left. But we do have some non-invasive therapies that have proven to work, are guideline recommended, that we're bringing into the system, and I think it's going to be a tremendous benefit to patients. And this is kind of a list of what we're doing for not only a primary prevention, which means preventing that first heart attack or stroke, but also the secondary prevention, preventing that second event. All of these things I think can be tailored to individuals. We're definitely looking at people that have hard to control high blood pressure, so if you've been working with a primary care doc and you're just not getting to where you need to be, we really specialize in this. If you've been on cholesterol medications and you just don't tolerate them, or you're not where you think you ought to be, or your doctor thinks you aren't where you ought to be, we specialize in this as well. I talk about a lot of these other things, so I don't want to go over it all. Now I want to talk about some of the things you can do, and I know your doctors have probably talked to you about this. A lot of this is intuitive. A lot of this is stuff you know. And part of the reason I showed you all that data up front was to get you to think about it the way I think about it. Because it's not just about you as an individual. It's about us as a country. It's about us as a community. How do we impact this? Because the things you do affect your children. The things your children do affect their children. And it's going to be a reciprocal thing. And we have to get off of that wheel, and we have to figure this out. One of the most important things you can do is be active. And I'm not talking about training for, triathlons. I'm not talking about training for even 5Ks. I ran my first year here was last year, and I ran the Irish Jig. And I was amazed at how many people were running it or walking it. And I think it's wonderful, and I think these are things that we can do on a daily basis. You don't need to spend an hour in the gym. We're really talking about 20 minutes a day, 30 minutes a day of just sustained aerobic activity. Enough where you feel like you're breathing a little bit harder, maybe can't have a normal conversation, but you don't have to be, really sweating or burning. It doesn't have to be a Richard Simmons video or anything along those lines. Do it in groups. We know people who exercise together stick with it, and it makes it more fun. And you don't have to do traditional exercises. You just have to be active. So figure out ways of things you like to do with other people. Find social groups, start social groups, and get this done. You are what you eat. I am the biggest believer in this. And, we see the consequences of what happens when you don't eat well all the time. And I've talked about those things. We are in a time now where there's more processed foods than there are whole foods. It's harder now than ever to eat well. And you have to figure out ways to force yourself to eat well. It's all available. I think if we kind of turn the tables on providers and say, hey, we need to eat healthier, we'll start getting healthier choices. We just haven't gotten there as a nation yet. But we know when you eat healthier, you feel better, you stay leaner, your outlook on life is better, you have more energy, everything improves. If you haven't heard about the Mediterranean diet, it's something I would definitely recommend that you read about. There's a ton of information out there about it. I am not a big advocate of huge diet changes. I think it's hard for people to go wholesale change from one way of eating to another. But you do have to think about all the things you're eating and figure out if those things can be taken out of your diet or if they should stay in the diet. The Mediterranean diet is really focused on plant-based proteins and fats versus animal-based proteins and fats. And it's a much healthier way to eat. It's the diet we have the most research on. It's the most vetted diet out there. You can go to any bookstore or look online for diets, and you'll see so many trends, and I can't even tell you what they mean. They're not studied, they are not sustainable for the most part. This is a very sustainable way of eating. It's not a major change to what you're already doing. It does change the composition of your diet, and because you're getting healthier fats, you're also getting less calories overall, which is really what helps you the most in terms of weight loss. People talk about having a tough time losing weight, and losing weight is really a calorie gain. For very few people, calories, there's almost nobody who won't reduce their calories who won't lose weight. When people talk about, I can't exercise to lose weight, exercise is wonderful for so many things in terms of reducing your risk, making you feel well, staving off dementia, staving off osteoporosis, improving your arthritis, that sort of thing. But it doesn't burn a lot of calories. You know, you could, if you can, jog for 20 minutes at a really fast pace, say 8 miles per hour. An 8-minute mile, that's what I'm trying to say. And you will burn less than 200 calories. That's not a lot of calories. You know, you can eat a granola bar, it's the same thing. So you put all that effort and energy into trying to burn calories, and it's absorbed by the smallest thing you eat. For me, exercise is not the reason why you don't exercise to lose weight. You figure out what you're eating to lose weight. And this is a hard thing to do. The average American is eating close to 3,000 calories a day right now. Most of us in this room need no more than 1,800 calories. We're almost doubling what we need in terms of calorie consumption on a daily basis. And you will lose weight. Your body has been accustomed to having that extra weight, having those extra calories. Your mind is attuned to it. It takes time. It takes 2 to 3 weeks to kind of get over that hump of the lower calorie reduction. But you have to think about what you're doing to your body. You know, we're not designed to carry all that extra weight. And I use this illustration here to kind of show, to try to kind of mentally show you what's going on. You know, our bodies are meant to be lean. That's how we were designed. And if you think about putting on, if you were lean, waking up in the morning every morning and throwing on a 30-pound backpack and wearing that all day long until you go to bed at night, it would be no wonder that you have back pain, hip pain, knee pain, ankle pain, be tired, be fatigued, feel worn out. This is what we're doing to ourselves every day. If you're one of that 20% still in this area of the state that's still smoking, this is what you gotta stop smoking. Every cigarette matters. Every time you smoke, you're causing inflammation in your body. You're damaging arteries. You're introducing carcinogens that are the beginning of cancer. And I tell everybody who smokes, you know, there's 3 things you predominantly get from smoking. You get cancer, you get cardiovascular disease, or you get lung disease. Nobody escapes. Everybody gets something. You might be unlucky and get all 3, you might be lucky and get 1, but nobody escapes. And never stop quitting. People have a hard time quitting. It's been proven that quitting smoking is harder than quitting a drug addiction. We know. So don't ever stop. Don't ever stop asking for help. We're there to help you. Sorry for the irreverent title here. But if you have medications, they're there for a reason. You know, when you look at the statistics on patients taking medications, it's alarming how many people stop their medications. About 40 to 50% of people who have had a heart attack stop the medications they were prescribed after the heart attack. Medications that are meant to prevent you from having another one, or from your heart function getting worse because of it. We specifically prescribe medications to treat your risk. We don't want you to have that next event. We don't want you to have the first event. And so we're giving you these medications to try to really lower your risk. If you're having trouble with medications, that's the perfect time to talk about it. You have to educate yourself about what these medications are for. You have to understand why you're using them, what the potential side effects are. When you read these package inserts, or you read about medications online, they all sound horrible. And I don't think I've ever met a patient who was excited to take a medication. And I understand that very well too. I don't like taking medications. But we have to understand that the reason we take them is to improve our lives, improve our chances of living a little bit longer, and in a lot of cases, feeling better. And I think if you do all of those things that we just talked about, not only do you have a healthier life, I think you have a richer life. To me, the most important thing really is not about how long you live, but how well you live. And I think if we focus on some of these things that I just talked about, that the AHA also focuses on, are you eating well? Are you active? Are you trying to lose weight? The chances that you have problems from being overweight, like diabetes, hypertension, high cholesterol, and the consequences of those things like heart attacks and stroke go way down. So thank you very much for the opportunity to speak to you, and I'd be happy to answer questions.
Looking at my iWatch while you were talking and seeing how many steps I've done today. I'm going to ask you that question. How many steps do we need to do each day? So at the end, remember, we're going to keep moving. Write your questions down so we can look through them in the question and answer session. Just one housekeeping thing. The temperature in the room is noted to be a bit cool, so we are adjusting that, so I apologize for that. Now, it's my great pleasure to introduce our next guest. CJ Mitchell is a colleague of mine. He's a clinical pharmacist who works in the cardiothoracic ICU at Spectrum Health. He's a very valued member of our team. And tonight he's going to be introducing his speakers and guests. And these this family who have joined us tonight were one of the people here was a patient in our intensive care. Earlier this evening, I hope you all had a chance to interact with the CPR demonstrations, because this story is about CPR, and CJ is going to share with us tonight the sort of importance of that chain reaction that occurs in that sequence of events from when someone has an incident with their heart and then the time until they get to the hospital. So a nice warm welcome to CJ. Thank you.
Good evening. My part is short and sweet tonight, so it's just the way that I like it. It's an honor to be here with you tonight and an honor to introduce our next speakers. I am a clinical pharmacist at Spectrum Health, specializing in cardiothoracic critical care. So I spent a lot of time in the ICU in the Meyer Heart Center and had the opportunity to play a small role in managing the care of a lot of patients who come in after heart attacks, after cardiac arrest, after significant cardiac events, through optimizing their drug therapy in the sometimes minutes and hours and days after their event. Our next speaker's story is one that is unfortunately far too common, but this is a story of certain success. I think it's common to consider the ICU a negative place and a sad place the majority of the time. But when you are there every day, you witness a lot of success and a lot of joy in taking patients, particularly those after cardiac arrest, who entered the hospital under the grimmest of circumstances, and who you get to see them recover and leave the intensive care unit and walk out of the hospital and get back to their families and their work and their lives. And certainly our next speaker's story is one in that category, and one certainly close to my heart, as I was able to provide or play a somewhat expanded role in their care compared to what is my normal. I'll leave most of the details to them, but suffice it to say, they are the walking, talking, breathing testament of all the things that we are advocating for tonight: the knowledge, the awareness, the skills. They are the definition of all of those things, and I'm so excited that they are here to share their story with you. So without further ado, please help me welcome two of my good friends and Spectrum Health Cardiac Arrest Program graduates, Mr. Mark Hagbaum and his wife, Sally Mahoney.
Good evening. My name is Sally Mahoney. This is my husband, Mark Hagman, and our family. There they are. That's our family, and that was a little over a year ago at our daughter Kara's wedding. We've been asked to share today about the importance of learning CPR. As recently as 9 months ago, I never thought I'd be standing in front of you sharing our story. We didn't even have a story. But now one's been created for us, and we feel called to share it with others in the hope that lives may be saved as a result. Our story began on a fateful summer afternoon in June while doing yard work. Mark is with us today because a series of miracles took place, all of which depended on the heart-sustaining power of CPR. The first miracle was that I went outside to see him right at the time that I did, and I was there when he fell in the garden. I was doing paperwork at the kitchen counter, and I looked up at the clock and realized it was 2:40 p.m. and we hadn't had lunch yet. I went out in the yard to admire Mark's handiwork and to suggest that he take a lunch break. He'd been working out there for a couple of hours, and as we talked and he showed me what he had accomplished, I watched in horror as he fell straight back and his head slammed into the house. Upon impact, his glasses broke and flew off his face into pieces. As Sue Toms noted in the MLife article that she wrote this fall, at the time I didn't know that my newlywed husband had suffered the heart attack often referred to as the Widowmaker. But I knew by the vacant look on his face that something catastrophic had happened. When I looked down following his fall, Mark's face was pure white. His eyes were rolled back in his head and his mouth was open. I thought that I'd lost him. As I pulled his body from the side of the house and onto ground level, I remembered what I'd learned several years before in a CPR class at my workplace. I honestly thought it was too late for Mark, but out of pure desperation, I began to put into action the training received several years ago, all the while screaming out, "Someone please help me, please call 911. Over and over, I screamed those words as long as I could for what seemed like an eternity. In reality, only about 2 to 3 minutes had passed when a neighbor that I'd never met, who lives around the corner and all the way down the street, heard my pleas for help and came running. He just happened to serve on the hospital code team that responds every time a patient goes into cardiac arrest. This would be miracle number 2. CJ performed CPR on Mark for at least another 13 minutes before the paramedics arrived with an AED. Altogether, Mark was out of pulse on that day for about 15 minutes. The cardiologist, surgeon, and nurses stressed that he may never wake following the 5-hour quadruple bypass surgery that ensued. They also said that if and when he did wake, his chances of having brain damage were extremely high. They predicted that he would have to slowly wean him off the breathing machine and that it could take a few days. Instead, miracle number 3 took place when Mark defied the odds and woke the morning after surgery on his own, and the ICU nurse removed the breathing tube about 2 hours later. He responded to a series of questions posed to him, and then he started asking questions of his own. Each time he heard the answer, he would simply say, "Wow." Miracle number 4 was that he suffered no brain damage. I do notice, however, that he seems to have a selective hearing loss sense. But perhaps that comes with the territory of being married for longer than a year and we're no longer considered newlyweds. Mark spent 8 days in the Fred and Lena Meyer Heart Center and many weeks in rehab, and went back to work just 7 weeks following his ordeal. I'm convinced that Mark would not be here today if CJ and I didn't know and administer CPR. Through all of this, Mark's learned to take better care of himself with a healthy heart diet and exercise, and has lost 35 pounds since his cardiac arrest. After losing the weight and walking daily, he has more energy than before, and he's been able to get off his pre-diabetes prescription and maintain his high blood pressure and cholesterol. By sharing our story, I hope that I've encouraged you to learn CPR and to never give up, even when the situation appears to be very grim. You never know what miracles will transpire as a result.
Here are several facts I've learned since my cardiac arrest. Most people feel helpless and don't know how to react during a cardiac emergency because they're not sure how to administer CPR or they're afraid of hurting the victim or loved one. Less than half the people who experience cardiac arrest can immediate help they need before professional rescue arrives. It was at least 15 minutes before the ambulance arrived at AED during my heart attack. The CPR given during that period of time helped get the flow of blood to my brain and vital organs. The fact that I've read since my incident, which I found even more alarming, is that only 1 in 10 people who suffer out of hospital cardiac arrest survive. We're all aware that knowing that CPR could save a family member, friend, co-worker, or person in need. Sally's efforts were so important to surviving my heart attack. In addition, I was fortunate CJ heard Sally's calls for help and was willing to join in my rescue. In college, I worked as a lifeguard and was able to save or rescue several drowning victims. I was also certified in CPR as a member of the National Ski Patrol, but in the 25 years on the patrol, I was never called upon to perform CPR. I'm truly thankful Sally and CJ implemented the skills they had learned. As we said at the beginning of our presentation, the photo was taken at our daughter Kara's wedding. We also have 2 younger children in the photo, Katie and AJ. One day they may marry in the future, and God has blessed me with the opportunity to share more family experiences each and every day. Everyone in this room tonight, I'm sure, can relate to this and has family and friends that mean the world to them. Just know, by taking a CPR class, you make a difference. Most out-of-hospital cardiac arrests happen at home. Remember, CPR, especially performed immediately, can double or triple a cardiac arrest victim's chances of survival.
I really am astounded at the courage of both of them to come and share their story, their advocacy for CPR, and that sequence of events, the chain of life, if you like. They're the sort of perfect outcome whereby someone drops down from a heart attack and you have a witnessed bystander who's able to provide cardiopulmonary resuscitation, and then they have the EMS with the defibrillator, a fast transit to hospital, and then under the hands of a cardiologist or the cardiac surgeons later on. I think the next 24 hours mark you had your surgery. So I'm just very grateful that they were able to share their story with us tonight, because I think it's very important for us all to hear stories like that, so that we can all take on board the responsibilities we have as a community to know about CPR. So thank you, and thank you for being here with us. Our next speaker this evening is Dr. Ryan Nader, who is a great colleague of mine. I'm very privileged to invite him up to the podium. So Dr. Nader's life is in the cath lab. He's the guy that fixes you when you have a heart attack. I just want to share with you some of his background. He's a board-certified interventional cardiologist and a fellow of the American College of Cardiology. He trained at the University of Pittsburgh. He also had his medicine residency at Washington University in St. Louis. And then he completed his cardiovascular training in Michigan at Beaumont Hospital in Royal Oak. And we're very privileged to have Ryan join our team at Spectrum. You've been with us for quite a few years now. So tonight, Ryan's going to share with you a presentation about heart attacks. Thanks, Ryan.
every time I hear her talk, she sounds so intelligent. The apology comes because I'm also not from around here. I'm from Pittsburgh. In Pittsburgh, we're known for having an accent that is crept out of West Virginia, and so I apologize if I don't sound as intelligent as that. So I titled this talk, Heart Attack 101, Practical Advice for the Future Patient. And for anybody in the audience who has had a heart attack, your chance of having a recurrent heart attack, even if you do everything right, take all the medications, don't smoke, eat healthy, your chance of having to come back in with another cardiovascular problem exceeds 20%. So 1 in 5 over anywhere from a 3 to 5 year period. So this talk, I think, is applicable for you. Anybody in the audience who has not had a cardiovascular problem, as we've heard tonight, 1 in 3 individuals are going to die of cardiovascular disease. This talk is relevant for you, and I'm going to actually give you 5 tips tonight. These are practical advice that I like to give all of my patients. And whereas Tom's talk was focused on how to keep out of trouble, how to prevent the first problem, these tips are for people who are in the active process of having a problem. And so I always like to start with a couple of cases. And the first case I'd like to present is that of a 52-year-old male. Has no history of heart disease, has never had a heart problem a day in his life. Actually goes out for a daily jog in the morning. He's known to be an avid runner. Recently ran a 12-mile race. After that, a couple days later, ran a 5-mile race. And unfortunately, while he was jogging, he suddenly collapses. Several bystanders actually attempted to resuscitate him. They were unsuccessful. He presented to the hospital, was pronounced dead. An autopsy was performed, and it showed that he died of a massive heart attack. And this is the story of Jim Fix, who died in 1984, July 20th, 1984. He was actually dubbed by the New York Times as the guru of running. A man in the peak of his career and fame, without any warning whatsoever, drops dead of a heart attack. I'd like to now fast forward approximately 30 years. This is a second case. A 51-year-old male, no history of coronary artery disease, actually is on vacation with his family. Spent all day sightseeing in Italy. Enjoyed dinner at a local restaurant with his family, returned to the hotel. Hotel staff actually said that he was in good spirits. But unfortunately, approximately 10 p.m., his 13-year-old son found him unconscious on the bathroom floor. Paramedics arrived, attempted to resuscitate him, and upon arrival to the hospital, he was pronounced dead. And this is the story of the death of James Gandolfini. Many of you probably know him as Tony Soprano, who starred in the HBO series Sopranos. He died of a sudden heart attack June 19th, 2013 at the age of 51. Absolutely no warning that this was going to take place. And so what these two cases illustrate is, we've come a long way in the last 30 years. You think about the technology that we had in the early 1980s, and you think about the technology that is available to us now. Technology has advanced in incredible ways, but the one thing that is still true, as was true with Jim Fix's death 30 years ago, as was true now with James Gandolfini, is we still cannot predict when a heart attack is going to take place, and we can't predict who is going to die of that. And this was true of Jim Fix and James Gandolfini. This was true of the journalistic icon Tim Russert, who died of a heart attack in his early 50s at NBC Studios in Washington. Again, absolutely no warning. And boy, we don't have to look very far along to find the next celebrity who again dies suddenly of a potential heart attack. And so I like this quote that was in one of the newspapers shortly after Tim Russert's death. Is Tim Russert's sudden death a warning to his generation? And I don't know the answer to that, but I think these cases illustrate a couple of things. Number one, as I've stated, they illustrate that we still can't predict a heart attack before it happens. Number two is that although heart attack prediction remains somewhat limited, heart attack treatment continues to advance. And so, as Penny had stated earlier in the evening, we have gotten very good at treating heart attacks. Prediction still remains a problem, but treatment is quite good. And as a potential future patient, there are several actions that you can take to enhance your chances of survival if you're unfortunate enough to experience a heart attack. And that's what the talk is going to focus on.
So I think we've heard a lot tonight about the scope of cardiovascular disease. There are roughly 1 million heart attacks per year in the United States. There are, on top of that, about 300,000 cases of sudden cardiac death where somebody just keels over without warning. And 80% of those were actually accounted for by underlying coronary artery disease. So again, this is a very common problem. Now, just so that we're all on the same page, what is a heart attack? Well, before we get into that, I think everybody needs to understand that the heart is a pump. It's a muscle. Its job is to pump blood, to supply blood to the vital organs of the body so that we can go on living. Now, the pump is supplied by several coronary arteries, and you can see them here in red. And these coronary arteries provide blood flow to the heart muscle so that the heart can do its job and continue pumping. Now, a heart attack is a situation where one of these coronary arteries suddenly becomes occluded. You have normal blood flow in the artery 1 second, next second the artery is occluded, and you're no longer supplying blood flow to the part of the heart that is supplied by that artery. That is what a heart attack is. Now, if you're lucky and can survive this event, come into the hospital, we can open this up and fix it. If you're unlucky, when this artery closes down, you can drop dead. And so what is it that causes most coronary occlusions? Why does this artery, which 1 minute has great blood flow in it, the next minute does not? Well, it has to do with the buildup of plaque in these arteries. And so plaque is cholesterol and other material that builds up in the walls of the artery over time, and you can see a cartoon illustration of this here. And so when this plaque builds up, most of the time it's quiet in the wall. You can go on living years with this plaque in your arteries and not know that it's there. But for reasons that we still don't completely understand, suddenly this plaque can rupture. The fibrous cap that covers the plaque can suddenly become disrupted. And when this plaque ruptures, a clot can form on top of the plaque. And it's actually the combination of the plaque in the wall of the artery, which is ruptured in most cases, and the clot that forms on top of it. It's that combination of the plaque and the clot together that actually occlude the artery and cause the sudden heart attack. And so I like this quote by the famous pathologist Erling Falk: why, after years of indolent growth, does an atherosclerotic plaque suddenly become complicated by life-threatening thrombosis? And we still don't know the answer to that, but what we do know is it seems to be related to the deposition of lipid within the wall of the artery. Now, why is a heart attack dangerous? Why is this such a dangerous thing when an artery suddenly becomes occluded? Well, number one is that the part of the heart that is fed by that artery can undergo permanent and irreversible damage. And so the heart is a pump. If you don't get this fixed, you're going to have permanent damage to your pump. And that can lead to a number of different problems, including chronic congestive heart failure. The second reason that a heart attack is dangerous, and as was the case with Jim Fix and James Gandolfini, is when that artery occludes and the heart muscle doesn't get good blood flow, that heart muscle can actually trigger a rhythm problem with the heart. And some of these rhythm problems that can get triggered in this setting of a heart attack can be life-threatening, and that's what causes people to die suddenly. And so the first practical advice, and again, if you remember nothing else from this talk, remember these 5 points, and this is the first of those 5 points. Call an ambulance. So the American Heart Association and the American College of Cardiology put out guidelines for all cardiologists and physicians to follow. And they're very clear in their guidelines that they say when patients develop symptoms of a heart attack, they should be referred immediately to the emergency department and transported by emergency medical services are available. And this is very important. Not only do you call an ambulance, but you don't have your relative drive you to the hospital. And prompt treatment of a heart attack is very, very important. And as you probably heard earlier in the evening, time is myocardium. Myocardium is just another word for heart muscle. And this is a saying that we say all the time in the hospitals, that time is myocardium. What that means is the longer your artery is occluded, the less benefit you're going to get from treatment. And so the longer you wait to call for help, the worse an outcome you're going to have. Now, if your artery occludes at the spot of this green arrow, that means that the entire front wall of the heart that is supplied by that artery is in jeopardy starting the very second that this artery occludes, starting the very second that your symptoms start. Now, if you come in for prompt treatment and we open this spot up, if you come in very quickly within the first hour or two, you may be left with no scar in your heart. You may actually have completely normal heart function if you come in very quickly. If you waited more than 2 hours, 3, 4 hours, that size of the scar that you're left with, even after we open up the artery again, you're left with a small scar. If you wait more time before you decide to come in, that scar gets bigger, even if we're successful at opening up the artery. And the longer you wait, the bigger scar that you're left with. And if you wait for 12 hours before you come in, even if we're successful at very promptly opening up that artery, it may be too late. The damage may be done, and next thing you know, the whole front wall of your heart doesn't work, and you're left with a very large scar. And so this slide, I think, very nicely illustrates why prompt treatment of a heart attack is so important. And so if you look at the bottom of this image, that's ischemic time. That's how long your symptoms are going on before you get treated. And you can see on the left side of the slide, that's your mortality at 1 year, a patient's mortality at 1 year. And so what you can see is that the longer you wait to come in to be treated, the higher your mortality is, the more likely you are to actually die of your heart attack. And in fact, for every 30-minute delay to treatment, your risk of death increases by about 7.5%. And so again, every 30 minutes you wait, the worse your outcome. And so practical advice, tip number 2 is do not wait. Waiting to see if chest pain improves is dangerous. Waiting increases your risk of death, as we've seen on the prior slide. It increases the size of heart attack that you have. You increase your risk of future congestive heart failure. Seek medical attention immediately. Remember, time is myocardium. And so at the AHA, American Heart Association, recently started a new public awareness campaign, which I think is very clever. It says, don't die of doubt. It may not be the heart attack that kills you. It's the fact that you doubted your symptoms, and that's what kills you. But I think these are 3 very nice quotes. Actually took care of a heart attack patient just recently. Started having symptoms. They knew something wasn't right. Their boss told them, why don't you lay down on the couch, you'll feel better in a little bit. And thankfully that patient did not heed that advice, came in right away. She did not die of doubt. And so how is a heart attack diagnosed? What can you expect if you come into the emergency room with symptoms of a heart attack? Well, number 1 is we get an electrocardiogram, also known as an ECG or EKG. And there are benchmarks that actually the emergency room staff at urgent care or in the emergency department, they are supposed to obtain an EKG on you within 10 minutes of arrival of symptoms. And so if you come into the hospital with symptoms of chest pain and 10 minutes passes and they have not got an EKG on you yet, let them know. They had 10 minutes, they missed the mark, better get it done. Number 2 is not only do we get an electrocardiogram looking for evidence of heart attack, but we get blood tests. And the blood tests that we get are called troponins. Now, troponins are enzymes that live and reside in heart muscle. And so if you're having a heart attack and your heart muscle is being damaged, this damaged heart muscle releases these troponins into the bloodstream, and we can detect these troponins with serial blood tests. And so again, these are the 2 principal ways that we diagnose a heart attack. Now, if you came into the hospital and had a heart attack, the appropriate treatment is then to have a cardiac catheterization. A cardiac catheterization is a procedure where a cardiologist feeds catheters, either from the groin or from the wrist or from a couple of other sites, up into the arteries of the heart. And we position the tip of the catheter into the artery. We then inject contrast dye into the artery so that we can see what the artery looks like. And this is a picture of a heart cath that I took on a patient not too long ago, and you can see this is what we're looking for. We're filling up these arteries with contrast so that we can try to identify the site of the blockage. Now, this day and age, there are principally 2 spots on the body that cardiologists access to do the heart cath. There's the radial approach, also known as the wrist, and there's the femoral approach, which is down in the groin. And there are differences, which I think are important for patients to understand between these 2 approaches. First and foremost, most people don't like having their groin poked with needles. So it is much more comfortable to go through the wrist than it is for the groin. So again, patient comfort is greater with the wrist approach. Number 2 is that the risk of bleeding is actually much lower with going through the arm compared to the groin. And actually bleeding in the setting of a heart cath is associated with an increase in mortality. So bleeding after a heart cath is a big deal. And in the setting of certain types of heart attacks, in fact, if you go in the wrist compared to the groin, The wrist approach, it actually is associated with a lower cause of all-cause mortality and fewer downstream cardiovascular events. So actually, going through the wrist saves lives in certain types of heart attacks. And so practical advice number 3 is if you go to the hospital with symptoms of a heart attack and you end up needing a heart cath, don't be afraid to request that the doctor goes through the wrist. Avoid drooling. Again, you will be more comfortable and your risk of having trouble during the heart cath or immediately afterwards is much less. So this is again that image that I showed before of a patient who was having a problem, and we took this angiogram to try to find the blockage, and I don't know if anybody sees it, but I pointed it out for you here. And so again, if we go back to this image, you can see where the blockage is. This artery is hanging on by a thread. A little trickle of flow is getting down through that blockage. And we've diagnosed where the problem is, why this patient came in with this issue. Now, what is the treatment? Once we find the blockage with the heart cath, what's the treatment? Well, the treatment is angioplasty and stenting. Angioplasty is simply a procedure where we pass a little balloon to the site of the blockage in the artery. We inflate the balloon and squish all of that blockage out of the way. And that restores blood flow in the artery. The next thing that we do is we put a stent in. And a stent traditionally is a manual or a metal scaffold that basically is deployed there. It is left in there permanently, and it keeps that artery open at that spot. That lowers the risk of that artery reoccluding and causing another heart attack. And so again, angioplasty and stenting is how these things are treated. And so if we go back to our case, this is me inflating an angioplasty balloon at that spot. You can see how small the balloon is. It's inflated to squish all of that blockage out of the way. You can see that blood flow in this artery is now restored, but you can see still where that little blockage is. And so I went ahead and deployed a stent. This is the stent being deployed at that spot. And this is what the artery looks like at the end of the case, now wide open with normal flow. The patient feels much better, goes home the next day. And so again, before treatment on the left, after treatment on the right. And so after stenting, if you had a stent performed, you're going to be on a number of medications. The medications serve several purposes. First and foremost, they are to reduce your risk of having another heart attack. The other thing that the stents do, however, is that they lower the risk that your stent is going to fail over time. And so there are a number of medications that I list here that actually help to keep the stent open. They help prevent blood clots from forming inside the stent. And so the importance of taking your medications after you have a stent cannot be overstated. You have to take your medications. And this is a research study that showed the importance of taking the medications. So on the left side, you can see the percentage of people dying after the stent goes in. And we see two curves here. The dotted line, the dashed one, shows people who stopped their medications prematurely. And the solid line, shown on the lower right, is people who continue to take their medications. And what it shows is there is a drastic increase in your likelihood of death if you stop taking your medications after a stent goes in. So you have to take the medications. And this was another study that listed all of the reasons they could find why a stent closed off, why a patient had a stent put in and then the stent closed off. And the thing that was most predictive of the stent misbehaving over time was actually people stopping their medications prematurely, stopping their medications before the cardiologist said it was safe to do so. And in fact, in this study, stopping the medications caused the risk of clotting the stent off to go up about 161 times people who did not stop their medications. So again, you got to take your medications. Tip number 4, take your medications. So I wanted to finish tonight just by talking about a couple of new technologies that we were very fortunate to have available at the Meyer Heart Center at Spectrum. The first novel technology is an intracoronary imaging device called near-infrared spectroscopy. And traditionally in cardiology, the pictures that we take of somebody's heart at the time of their heart attack are the angiograms or the caths that I showed you earlier, where we're taking x-rays of the arteries and we can see them on the screen. We now have a number of imaging tools available to us where we can actually put these little tiny imaging catheters into the arteries themselves and take pictures inside the artery to see what the artery looks like on the inside. And one of these is near-infrared spectroscopy, an example of which is shown here. And what this does is it finds where the cholesterol is deposited in your artery. And cholesterol in an artery looks like big yellow blobs like you see here. Anywhere that we see that's red, has no lipid, places that are yellow, it shows the cholesterol. And that cholesterol, those big yellow accumulations that you see here, those are what cause heart attacks. And so one of the studies that we recently published was that when we use this technology, at the time somebody comes in with a heart attack, after we fix the trouble spot with the stent, if we then scan that artery with this near-infrared spectroscopy and find a lot of lipid, that the more lipid you have in that artery, the higher your risk of having future cardiovascular events. And so this is a new technology that we think we can use to pick out who is at higher risk of having another problem. The second new technology that I wanted to mention, and we are one of only about 20 sites worldwide that actually have this technology, is robotics. We have now, for almost 2 years, been doing stent procedures in the cath lab using a robot. And the reason I think this might be important for patients is with the robot, we can achieve a level of precision with our stent placement that is more than we think we can achieve manually. So it increases potentially the precision of our procedures. And so these are images of how catheterizations have been done, how stents have been done over the ages. And this robot, what it does, it basically has two components. It has a bedside robotic arm that serves as our hands at the table, and it has an interventional cockpit, whereas me as the operating physician, I sit in this cockpit and I actually put the stent in while sitting in the cockpit. And so, whereas you can see what putting stents in used to look like, this is what putting stents in at Spectrum Health now looks like. It's an operator actually sitting here in the lower right, that's me sitting in the interventional cockpit. I have my assistants at the table, but I put the stent in using robotic technology. And again, I think this robotic technology is probably only going to expand over time, and we're very fortunate, I think, to have this technology today. The third novel technology that I think that the audience should be aware of is not yet available in the United States, but we anticipate that it will be in the next year or so. And these are bioresorbable, also known as disappearing stents. And so, since the first stents went in decades ago, all of the stents that we still currently put in are made of metal. And so, when the stent gets put in, that stent is going to outlast you. It will be in there for all of your days. And the problem is that even stents that perform very well for the first couple of years, down the road, even 10 years later, can develop scar tissue in them and cause trouble. And so, you know, if we could fix an artery without leaving something permanent behind, that potentially may be better. And so there are a number of companies now developing bioresorbable stents where you put the stent in, fix the problem, and over a 2-year period, the stent actually disappears. And so that 2 years later, there's nothing left behind in the artery except a well-healed artery. So again, this is a very interesting technology that we should have available in the United States hopefully soon. And so tip number 5, again, the last piece of advice is do not be afraid to ask your physicians about new technology. We always have new things coming out. We're fortunate to be in a healthcare system that allows us to be on the cutting edge of these things. Ask your physicians about new technology. And so again, just to review these 5 tips, if you remember nothing else tonight, please remember these 5 tips. They could save your life. Number 1, call an ambulance. Don't drive yourself. Don't have your relative drive you. If your heart's going to stop because you're having a heart attack, it's better to be in the ambulance rather than sitting next to your spouse. Tip number 2, do not die of doubt. We see people every year, every week really, who sat at home with their heart attack symptoms, not knowing what it was that they were feeling. Should I go in? Should I not? If something feels not right, seek medical attention immediately. Tip number 3, if you're going to have a heart cath, don't be afraid to ask for radial. It's associated with greater patient comfort and less bleeding, and in the setting of certain types of heart attack, a lower mortality rate. Tip number 4, take your medications. Don't let other non-cardiologists tell you to stop your medications. Don't let your dentist tell you to stop medications. Only your cardiologist should stop your medications. Very important. And then tip number 5, don't be afraid to ask about new technology. We always have new stuff coming out. Thank you.
Thanks, Dr. Maida. That was a fantastic talk. And I have to share with the audience that Dr. Maida is a very intelligent researcher, and his research that that he performed on that lipid plaque that you saw before, the near-infrared spectroscopy, was noted in Science magazine about a year or so ago. Discovery magazine, that's right, as one of the, it was ranked in a top 100 breakthrough studies. So I'm very privileged to work with Ryan. He's a fantastic researcher, and I think his work in sort of predictive heart attacks is going to really change the way cardiologists in the cath lab will deal with patients in the future. So now we get on to the best part of the evening that you've all been waiting for, and tonight, it's known as the Doctor Dialogue. So we're going to start our conversation. I know you've all been waiting patiently, so I'd like to open up the floor to you, and I'd like you to get those questions out, and we've got some trackers walking around the room with microphones. If you put your hand up, we'll take the questions, and I've got my experts to answer them. So I think we've got a gentleman over there.
Can we go back and replay the 5 tips?
Sure.
Oh, sure.
So the 5 tips, we should write those down. I'm going to ask a question just to get us started, and it's about exercise. So while you were talking, Tom, I was thinking, sitting is actually the new smoking. I don't know if any of you have heard that, but it is. And so I was looking at my iWatch today, my Apple iWatch, and I know that I've done 5,096 steps. So Tom, my question to you is, if you're not going to go exercising like running and swimming, how many steps should we be roughly walking a day? And if you don't have a watch or a Fitbit to measure it, what would you recommend in terms of just walking?
The recommendation for walking on a daily basis is really 10,000 steps. That's a lot of steps. It's easily achievable if you're not sitting. You'd be surprised if you just stand up how many extra steps you get. And if you're not walking, even standing is better than sitting. So a lot of us, I don't know if Ryan does this, I do this all the time. I spent my whole day today in the testing center looking at echoes and other stress tests. I spent the whole day standing while I was doing that. And it may not be as active as getting 10,000 steps, but it's not as sedentary as sitting, so it's good for you.
And take the stairs. Don't take the lift, or as the Americans say, the elevator.
That's right.
So, okay, there must be some questions out there. I think we've got one over there, or two.
I have a question. What is the latest on Tycor? This gentleman cannot take a statin. Is there an option?
So, the best medications we have right now, as far as risk reduction is concerned, are statin medications. And we run a statin intolerance clinic, and I think, when I was at the University of Michigan getting my prevention training after my general cardiology training, there was almost nobody we couldn't get on a statin medication. Tricor and other medications are great at treating triglycerides, but they're not necessarily great at treating other types of cholesterol abnormalities that we think right now drive the risk of having heart attacks and strokes. So it's not a bad alternative, but I think there's other ways of approaching it.
Thank you. There's another question over there.
I've heard that inflammation is more of a problem than high cholesterol for cardiac disease. Is that true?
There's many factors that go into cardiac disease. Inflammation is absolutely one of them. Inflammation damages arteries, like Ryan was showing you. Cholesterol, once arteries are damaged, we get into the walls of those arteries. So there's lots of different things, lots of different mechanisms that cause the plaque buildup. But it's absolutely, we know it's one of those things because there's people with rheumatologic diseases like rheumatoid arthritis or other things that have underlying inflammatory conditions that don't necessarily have those other traditional risk factors like high blood pressure, high cholesterol, diabetes, that we see a much higher incidence of cardiovascular disease in. So we know it's one of those things. But I wouldn't say it's more important than cholesterol.
Thank you. I have a second question. Why is the high stroke rate
think it's multifactorial. I think, what we saw is we are doing a really bad job of controlling our risk factors. And risk factors don't just cause heart disease, they cause vascular disease. One of the things that both of us didn't talk about is peripheral vascular disease, which stroke is a part of. But lots of people get disease in their legs and they have problems walking. And I think the stroke rate is getting higher because our blood pressure is going up, down because our weight's going up, and because we're getting more sedentary. We're doing worse with our blood pressure control, our cholesterol control, and diabetes. It's all part of the same package.
So lifestyle.
Yeah, absolutely. If we changed our lifestyles, I think we would have a dramatic decline in cardiovascular disease.
Thanks, Tom. I think we've got a question over there at the back.
The question I have is many people, especially young people, seem to be moving from traditional cigarettes to those vapor cigarettes. Has there been enough time to do research? They say, of course, they're so much better, they're healthier. What is your opinion?
My opinion, my opinion is that no smoking is good for you. And the thing I can tell you is we have mountains of data on cigarette smoking to tell you how bad it is. We had mountains of data on cigarette smoking that the government had before they ever released it. We don't know really much about vapor cigarettes. They haven't been around long enough, we haven't collected data long enough, and it takes time to collect data to figure out things that it might be doing kind of in the short term, but it also takes time to collect data to see what it does to you in the long term that cause heart attacks or stroke. So I tell patients, I don't want to see them smoking anything. Yes, I would rather see them smoke vapor than cigarettes, but I would also only say that if they're using it as a means to get off cigarettes and vapor altogether.
Thanks, Tom. I think we've got a question over there.
I have two questions for Dr. Mayer. I was wondering if the radial approach to a heart cath is better than the femoral approach. Why even try the femoral approach?
So if you go back in the United States, certainly 10 years ago, probably 5 years ago, almost everybody was still using femoral. Part of the reason for that is that we did not have equipment available to us that made the radial approach feasible. And so you can imagine that the femoral artery in the groin is actually a fairly big artery, whereas the radial artery in the wrist is a very small artery. So we did not have equipment that was small enough to allow us to safely and reliably get in the wrist. And that has now changed. And we've seen just at our heart center, even over the last 5 years, a big uptick in cases that are being done radially. Not all cardiologists have been trained in the radial approach, but now I think most of us here in Grand Rapids, do radial. I do radial for almost all of my cases. That's because that's what patients want, and it's nice to see patients, words getting out, finally coming in and asking for it, which I think again improves their chances of having a good outcome.
Okay, one other question. Do the stents ever come loose and move in the arteries?
Stents very rarely, when we are deploying them, can come loose. It's a very rare complication. It is much more rare even these days because the technology has gotten so much better. And so it's a very, very rare complication. Once the stent is deployed and it's in the artery, it can't go anywhere.
Thank you.
I have a question. Over here.
Right? I'm sorry.
Oh,
there we go.
I didn't understand, but can you tell me if drinking 4 ounces of wine, red wine per day is beneficial for the heart and lowers cholesterol?
I don't know, but it sounds fun. And Tom, maybe you can speak for prevention. There are data that exist that have shown some benefits to red wine. I think recently it's been contested a little bit, so the jury may still be out.
The data still supports for a woman having no more than 1 glass of wine a day, for men no more than 2. Some of that's body size dependent, but we do know that if you drink more than a glass a day, any health benefit you're getting from the wine gets eliminated. And if you drink more than a couple, you're actually adding risk. As far as lowering the cholesterol is concerned, it has more to do with raising the good cholesterol than it does lowering the bad. So, that answers your question.
I just want to make sure anyone at the front who has a question gets an opportunity. We've got a lady right here.
I just want to know if you're going to a doctor, like your internist, and getting treated with your high blood pressure medications and all that kind of stuff, and you have a history of heart conditions in your family, how do you convince your internist to perhaps recommend going to something?
Do you want to just
I'll repeat the question. Yeah. So the question was, if you're seeing your primary care doctor and you have certain risk factors like high blood pressure or high cholesterol, but you also have a family history of heart disease, how do you convince your primary care doctor to see a prevention specialist or a cardiologist? I would tell you, if you want to see someone like me or a cardiologist, self-refer. You don't have to get a referral from your cardiologist for most insurances. I think if you ask your primary care provider, hey, I'd like to go see a cardiologist to discuss my risk, there's not a single primary care doctor that would turn you down for that. And I think if you have a strong family history, it's always worth having a second conversation about. I always tell patients, if you feel like you need a second opinion, or a third opinion, or a fourth opinion, get it. The most important thing is that you're comfortable with the care you're receiving, you're knowledgeable about the care you're receiving, so that you do the things we can do.
There's a question over here.
Could you give us some comments about what part genetics plays in heart disease? I'm a person that for many years took aerobics. I had a healthy diet for this time, doing everything right. And 2 years ago, at the age of 83, I ended up with pneumonia and congestive heart failure. 3 months later, I had open heart surgery, quadruple bypass, and mitral valve repair. I was in the hospital for 3 weeks, only because one of the tubes wouldn't quit draining. I did well, and then I got no surgery, and then I went for cardiac rehab after that. Went home, and for several months was doing right. Thank goodness for Spectrum Health and the cardiac rehab that they had. Then, the day after Labor Day in September, guess what? I had a cardiac arrest at home. And thanks to my husband and daughter who responded quickly, and the first responders who acted quickly. No pulse, it was CPR, got me to your special place there at Minor Guard with all of their special angels of mercy and miracle workers. Thank you. I'm surviving.
Question about genetics in there, is that right? Yeah, so there clearly is a genetic component to heart disease, and we see patients that come in with heart attacks that have no risk factors other than that they had a relative, their mother or father, who at a very early age, developed heart disease, and so clearly there is a genetic component to it. And if you do have a family history of heart disease, you should be more vigilant, in my opinion, and you should seek preventative strategies at an earlier stage.
Thank you. I think there was another one.
You have another question? So the question is, what causes inflammation in the body? And there's a lot of things that can do that. I think in general, if you don't have underlying inflammatory conditions, things like stress, anger, poor sleep, some of these medical conditions like diabetes can do it, high blood pressure, because the walls of your arteries are always under stress and cause the release of chemicals into the bloodstream that result in inflammation. Smoking causes it. There's a lot of things that cause inflammation in the body.
Any other questions?
Yeah.
How important is it to take a baby aspirin for someone over 65, and are there exceptions? Or should everybody take it?
Sure.
So I'll let Tom speak about people who have not had a prior cardiovascular event, but for people who have had a heart attack or have had a stent put in, we are still recommending a baby aspirin a day
So the data does not really support baby aspirin for people who have not had heart attacks or don't have known coronary artery disease. The data shows us that there's really no change in whether you live or die if you're taking the aspirin. I mean, it might have a slightly higher bleeding risk if you're taking it. What I tell patients is I look at everything, not just whether or not I know you have coronary artery disease. If you're coming to talk to me and you have lots of risk factors, but you haven't had an event, or you've never had a stress test and under a cath lab, we don't know anything about your coronary arteries. If you have lots of risk factors, you have a strong family history, you know, I say if you feel more comfortable taking an aspirin to try to prevent a heart attack, that's fine. You just have to understand there's a little higher risk of potentially having bleeding complications or bruising complications.
Yeah, because if that person suggested it, and it seems like most of my friends are taking it, so I.
Yeah. I mean, a lot of people take it because they think they're going to reduce their risk. If you don't have known disease, we don't have any data to support that it does reduce your risk. But there's a lot of people out there that don't have known disease. You know, they haven't had a symptom, they haven't had it evaluated. There's other ways other than heart catheterization to look for heart disease. We do things called calcium scores that look for calcified plaque in the arteries of the heart. If you have kind of atypical symptoms and you don't want to go through an invasive test, we can do a CT angiogram looking for it. Stress tests are designed to look for heart disease, but they're usually designed to find people who have symptoms. So there's lots of different ways of looking for it.
There's another question in the back.
A few days ago, there was an article on the internet about Larry Bird, the basketball player from Indiana, and he commented that he didn't expect to live over 60 years old because of his height. I think he's about 6'6", 6'7", and he said he cited a number of examples of former basketball players who really were not overweight or had obvious risk factors. Is there any association between height and incidence of cardiovascular disease?
Not that I know of.
Yeah.
And if it is for height, I'm glad I'm short. From one time I
Yeah, actually there was a recent study that looked at how height impacts risk, and I'm not familiar enough with the details, but I'm sure you can find it online if you look it up.
Okay, I think we got a question down here, and then there's a lady over there. So.
I just have a question on the aspirin thing. They say sometimes if you think you are having a cardiac event, to take aspirin. So is that something you should still do? And is it like 2 aspirin?
Yeah, I would definitely recommend it. To me, there's no downside to it, and the data shows you that the best thing you can do prior to getting to the hospital quickly is taking that.
Okay, I just wanted to.
But do not take the approach, and I can't tell you how many times I've seen this, that somebody takes an aspirin, waits to see if their symptoms go away with the aspirin before they actually call, and I think we see that all the time. And again, you're just wasting time. Call an ambulance, and if you want to take an aspirin, fine. Actually, some of the older research, before we had stents and angioplasty for heart attacks, we used to routinely give clot-busting medications that you give through an IV that actually breaks up the clot. And when that was compared to aspirin, actually both of them were found to be equivalent. The aspirin gave you just as much benefit as getting one of these clot-busting medicines. One adult aspirin is what we give in the hospital.
Okay, we've just got a couple more minutes for questions. I think this lady at the front here is one.
And this has to do with baby aspirin also. I've had a small stroke, and my doctor told me I have to take baby aspirin every day. But you sound like I don't need to. I don't have a, heart disease.
So if you've had a stroke, that technically is a cardiovascular event, and the research would support taking a baby aspirin a day in that situation as a way to reduce your risk of a recurrent stroke. Tom, I don't know if you have that.
No, I would 100% agree with that.
Okay, we'll take one last question.
Yes, can you define congestive heart failure?
Congestive heart failure. Who wants to take that, Ryan?
Yeah, I'm sorry. Who? Can you stand up? There you are. Sorry, the lights are bright. Yeah, so congestive heart failure is a situation. The most common symptom is that one cannot breathe easily. easily or one feels fatigued with either at rest or with various activities. The technical definition is that the heart cannot meet the body's demands and provide enough oxygen, or can only do so with the pressures of the heart being elevated. And so most of the time, though, when you hear of somebody coming in with congestive heart failure, usually it's because their lungs got a little bit fluid overloaded. And that's a situation that we treat with medications to dry out the lungs. It may or may not mean that the heart is also weak. You can actually have normal heart strength and still get congestive heart failure.
Thank you. I can see a couple of hands going up and down, and what I'd suggest, if you've still got questions, because we're sort of running out of time, write your question down clearly with your email address, and then we will endeavour to respond to it. Because I can see there's quite a lot of people that still have questions.
Thank you, Penny. Yes, and we also can post answers to some of the questions we've received already on our social media sites. So please be sure to check Twitter and Facebook, where we will put some of the questions and answers after the event. And again, please add your email address. Thank you, Penny.
So thanks for everyone's participation tonight. This is a really important event, and I'd like to ask Tracy up to the stage, the podium, I should say, to close the evening for us.
Yes, thank you, Dr. Boyden. Again, thank you all for coming. We know it gets a little late in the evening, but we thank you for your time and attention tonight. Make sure you fill out those surveys. We really want to make sure we get your feedback and any other topics. We brought up stroke tonight. If that's something you think we should talk about next year, please let us know that. Peripheral vascular disease, we talked about kind of the blood flow to our legs and feet, and if we want to talk about that, if you want to know more about exercise prevention, anything that is top of mind for you, please put those on your surveys, and we'll collect them kind of as you exit, so we can have another wonderful event next year. So thank you for